Welcome to Our Toxic Nation, a call for Reformation Summit. I'm your host, Rachel Roshek, and I'm excited to announce today's guest and topic today with Dr. Shannon Delaney. Welcome.
Thanks, Rachel. Thanks for having me.
Thanks for being here. The topic today is psychiatric presentation of vector-borne diseases, but first I would like to introduce you to our audience. Dr. Shannon Delaney earned her medical degree from the Medical College of Wisconsin in 2009. She completed her residency training in adult psychiatry at Harvard Medical School in 2012 and completed her clinical child and adolescent psychiatry fellowship at Columbia Cornell in 2014. She pursued a 3-year National Institute of Health-sponsored research fellowship at Columbia University studying immune and infectious biomarkers of psychosis with Dr. Brian Fallon as her mentor. She joined the faculty at Columbia University Irving Medical Center in 2017, doing a mix of clinical and research work. While there, she specialized in seeing children and adults with complex neuropsychiatric presentations after suspected Lyme disease or other tick-borne diseases, as well as PANDAS patients. In July of 2023, she started a private practice in Manhattan, specializing in complex neuropsychiatric presentations related to the infections in kids and adults. All right, so I'm just going to jump right in.
Sure.
Can you explain the connection between Lyme disease and psychiatric symptoms? Kind of what's happening in the body and brain that leads to these symptoms?
Sure, I'll do my best. So with infections like Lyme disease and frankly other infections that you can get in a tick, they can cause a lot of neuropsychiatric symptoms. So I predominantly see people who are presenting with neurological symptoms from these infections and also psychiatric symptoms, and it's usually a combination of the two, which would be what we would call neuropsychiatric. And my best guess is that we're seeing psychiatric symptoms because the infection is in the brain. But there's probably a lot of different kind of ways that infections can give people psychiatric symptoms. So it could be physically changing the anatomy of your brain. The infection can be in your brain. We know that anytime someone has an ongoing infection, we see increased inflammation. So oftentimes, for example, if someone is sick and we start antibiotics, we can see symptoms worsening in the first few days of the antibiotic treatment. And that's probably related to increased inflammation. So there's a lot of, you probably heard about cytokine storm with people who had COVID. So same kind of thing happens with Lyme disease, or for example, if someone has Lyme disease and we start treating it, you see increase in cytokines, which are just basically proteins that the immune system makes, like molecules of communication within the immune system. But anytime you have increased inflammation, you can see cytokines, like a significant increase in cytokines. And it just kind of depends from an infection standpoint. Sometimes I can see people who come in with the same infection having only neurological symptoms. Other people with the same infection can only have psychiatric symptoms. So these infections have a tropism for the brain. So they like brain tissue. And we don't know why some people develop neurological symptoms and so why some people develop psychiatric symptoms. But in short, the infection is really is causing damage to the brain. And so that's why we see things like psychiatric symptoms. And then in terms of like long-term chronic infections, we're probably seeing that the infection or those cytokines that I was telling you about, or any other immune dysregulation, is probably changing the circuits in your brain. So the brain is complicated. You know, there's lots of complicated neurobiology that goes on to make people like be happy and be in their resting state. And anytime you kind of tweak with that, and an infection in the brain obviously is affecting that, it can change your neurobiology. So that means your brain chemicals that are important to keep us like happy and healthy, like dopamine, norepinephrine, serotonin, all of those, they help with keeping your mood stable. They help with focus. All of those can be off when you have an infection.
Got it. What are some of the most common psychiatric symptoms you see in Lyme patients, and are they typically mistaken for other mental health conditions?
Yeah, that's a good question. So, I'm a psychiatrist by training. I'm a child psychiatrist also, which means I see adults, but I also see a lot of kids. And I can tell you I've seriously seen the entire gamut of psychiatric symptoms related to these infections. And I probably wouldn't believe it if I wasn't a doctor who saw it every single day in my practice. But I would say the most common symptoms that we see in the adult population would probably be anxiety, depression. On occasion, I also see adults that present with psychosis related to either Lyme disease or, in particular, Bartonella infection, which is another infection you can get from ticks, but you can get it a lot of other ways. Like you can get it from cat scratches, you can get it from ticks, like I said, lice, fleas, house spiders, sand flies, and probably biting flies too. So Bartonella is kind of scary in the sense that it can also cause these psychiatric symptoms like Lyme disease, but there's just a lot of different vectors in which you can get Bartonella. So that is sort of the adult population, I would say, predominantly like sometimes very severe anxiety, depression, and sometimes suicidal thoughts along with anxiety and depression, and then sometimes psychosis from a kid's standpoint when they get these infections. One of the interesting things is that usually when adults get infections like Lyme disease, we see other more medical symptoms coming along with them. Not always, but usually we'll see other symptoms like fatigue, joint pain, problems thinking, and the psychiatric symptoms. By the way, we also can see in general mood disturbances. So, for example, bipolar disorder, symptoms of mania, depression in the adult population too. But the point I was going to make with adults is that usually we see joint pain, fatigue, those kinds of things along with the psychiatric symptoms. But for kids, oftentimes they will present only with the psychiatric symptoms. So that's even scarier because
Yeah.
somebody who presents only with psychiatric symptoms, if you don't go to a doctor who understands the link between infections and psychiatric symptoms, it's easy to miss, basically. So with kids, I would say the most common symptom I see is OCD related to these infections. Anxiety, depression, and OCD is kind of like a trifecta. Oftentimes with kids, they often present with tics also, so abnormal movements. Also, I see a lot of psychosis in children too related to these infections. So it can be very scary. We see a lot of kids who have a abrupt change in their personality. So this can be like a calm, kind of collected kid with like no major problems. And then all of a sudden, kind of out of the blue, the parents notice a significant personality change where they get very upset. We see these kids becoming like going into these rage episodes sometimes where they like destroy their classroom. All of a sudden, their personality, I've heard from so many parents that it feels like their child is possessed. Like they say it over and over again. So it can be a very scary experience for these parents to see their child changing their personality in front of them. And this is not an unusual phenomenon. Like I see this all the time. So that's really something important for listeners to kind of take home is that with kids, it's not uncommon with these infections to only see psychiatric symptoms and not have symptoms like fatigue and joint pain and problems thinking. Sometimes we do see that in kids, but it's frequent that I'll only see the psychiatric manifestations of the disease.
Oh. How important is early diagnosis of Lyme disease in preventing these symptoms from becoming a long-term problem? Like, can psychiatric symptoms improve with proper Lyme treatment?
Yeah, I mean, if the psychiatric symptoms are related to the infection, which is
Mm,
most of what I see, they can 100% improve. Um,
great.
and early diagnosis is probably the most important piece of all of this. I actually am starting to see people a lot earlier because I'm kind of connected with therapists and I'm connected with psychologists who do like neuropsychiatric evaluations, for example. And once other mental health providers are able to identify that this doesn't seem like a so-called typical psychiatric presentation, I've been seeing these kids a lot earlier, and it's so rewarding because we can make the diagnosis, like as a team, we can make the diagnosis much faster. And it's a world of difference. A kid getting diagnosed within a few months even of the infection, or within a few months of the presentation of the infection. One of the complicated things about these infections is that they always don't present right when the person is getting infected. These infections can really be latent and very stealthy for long periods of time, and then all of a sudden emerge out of the blue. But when we can identify what's going on within the first few months, it's like a game changer compared to someone who's been sick for many, many months, because typically they just continue to develop worsening symptoms. It's much harder to treat when you're like a year or two into this process versus like a couple of months in.
Yes, I can tell you from personal experience that what you're saying is absolutely correct. And I find what you do fascinating. What motivated you to specialize in the intersection of Lyme disease and psychiatric health? And how has this work shaped your understanding of the mind-body connection?
A little bit of a long answer, but I'll do my best to try to answer it completely. So it goes back many, many years now. I did my residency. So I finished med school back in 2009 and started a residency in Boston. And during that time, that was right around the time where the autoimmune condition NMDA receptor antibody encephalitis was being discovered. I don't know if you know that condition, but
No, I don't.
so it's a condition where basically it's an autoimmune reaction that is usually triggered by an infection. And typically these patients who have this particular condition usually present with psychosis first. So psychosis, or maybe like mania that looks like bipolar disorder. And usually in the typical kind of way that the encephalitis evolves, they then get very sick, and after they start with psychiatric symptoms, then they get much worsening neurological symptoms, and they often end up in the ICU because they're having seizures and things like that. So they just identified the antibody that was causing this presentation back when I was an intern in 2009, and it's called NMDA receptor antibody encephalitis. And again, all of these patients, or most of them, were presenting first with psychosis. So I thought it was fascinating as like an intern in psychiatry, because obviously at that point we basically we didn't know what caused most psychiatric problems. It's just like we have medications and drugs that we use to help the symptoms, but we never really knew the underlying root cause. So here's a particular condition where it's triggered by an infection, and what happens, it's called like a molecular mimicry event. So you have an infection, the immune system is making an antibody to target the infection, but instead of hitting the infection, it basically is cross-reacting to self tissue, so brain tissue, because that part of the brain has a protein sequence that's similar to the infection. And so in this particular situation, you're creating an NMDA receptor antibody that's attacking that area of the brain, and it gives people psychosis, and then it like gives them severe neurological problems too, because the NMDA receptor is like plays an important role in the brain. So that got me thinking. It was a fascinating thing that they're still discovering in 2009. So that part is kind of crazy that we're still like understanding all of this. But back then it got me thinking, well, what if there are all of these people stuck in psychiatric hospitals who actually have an autoimmune condition, and that's what's driving their psychosis. So at that point I decided that I was like more intrigued with the research path. And then at the same time, I was just going through all my clinical work. And as a psychiatrist, when you're going through residency and also going through fellowship, you have to work in the hospital, and you have to do something called consultation liaison work. And what that means is that people are hospitalized for medical reasons. I mean, we worked in the psychiatric hospital too, but in this circumstance, these are like patients who are coming in for medical problems. They're in the hospital trying to treat their medical issues. And time after time after time, the psychiatrist would be called to evaluate these really complex patients that nobody really knows what's going on from a medical diagnostic standpoint. And so after they do like the multi-million-dollar workup on these patients and they don't find anything, they basically like don't know what else to do. So they call the psych team in. So this is what happens normally in the hospital. And so you can imagine what a sick patient and their family, how they feel when they have to talk to a psychiatrist when they're like, I have all these medical problems. I don't want to talk to a psychiatrist. This is not a mental problem. So they get kind of angry. So I would see all these patients because I was part of the psych team. And I always found myself like sort of being on the side of the patient and family. I would hear their story and I would not think that there's some psychodynamic or analytical problem that's causing their symptoms, even though the like attending psychiatrist would often like come up with that as a solution. I never agreed with that. And I was just like, this is ridiculous. This is obviously a medical problem that we just don't have answers to because the science is just not evolved enough or advanced enough for us to understand what's happening with them. So basically, it's a long answer to say that it was a combination of like me being intellectually interested with the whole NMDA receptor antibody encephalitis. Also, PANS PANDAS is the acronym that describes psychiatric symptoms that these kids can get after infections. So that was becoming like more on the scene. And then I had all of these like repeated episodes in the hospital. And it wasn't just, it was like different geographical regions too. So I did my residency in Boston, I did my fellowship in New York, and I encountered it like across like different cities, also with the child population and the adult population. And so it was enough to make me think, okay, I should really like be studying this more. So that's why I ended up doing the 3-year research fellowship where I was really interested in recruiting patients with psychosis. And this is because of the NMDA receptor antibody encephalitis. I recruited patients with psychosis and I was looking at a lot of immune and infectious biomarkers. And during that time, I picked a mentor, Dr. Brian Fallon, who was in the Lyme disease world at Columbia. So by virtue of him being my research mentor, I went to their lab meetings and I learned a lot about Lyme disease and how these infections can give people psychiatric symptoms. And so then when I finished my fellowship, it was just natural for me to stay on and start continuing to do work and research related to Lyme disease. So that's how I got into Lyme disease specifically.
Well, thank you for, doing what you're doing. I'm a Lyme disease patient and I was misdiagnosed as bipolar 2 along with a handful of other conditions for 8 years. And so it's really refreshing to hear that there are psychiatrists that are now getting involved in, this part of health instead of it just being medication. Um,
Yeah, sorry about your misdiagnosis. There's a lot,
y-
there's a lot
yeah,
about these conditions.
yeah. And I'm not the only one. I mean, there's so many more people out there like me, so it's part of why I'm doing this interview series. Where do you see research around Lyme disease and its psychiatric implications headed in the next few years? Is there anything you're particularly excited about, or any breakthroughs or emerging therapies? Anything?
Um, to be honest, I'm kind of out of the research world now since I'm in private practice and I left Columbia.
Mhm.
But I feel like I'm a little bit in a silo, and myself and my colleagues who see all of these patients, like this is what we see day in and day out. We see neuropsychiatric symptoms, but especially psychiatric symptoms from all of these infections. And it's almost surreal, to tell you the truth, to the extent that like this is what I see all day long. And so and by the way, we treat people for these infections and they get better. And so it's almost as if we're living in this world, weird, like parallel universe where this is all I see. And so I'm like the biggest believer because this is my entire world. But then you step just away from this a little bit, and most doctors have no like knowledge of the fact that kids or adults can have these neuropsychiatric symptoms from these infections. So that's where I wish research would go, and like in another lifetime, or like maybe in like a decade or so, or in an ideal world in a few years, I would love to be able to collect research samples just on my clinical population, because there's so many basic scientists out there who are actually studying these infections, and they need blood samples from patients who have like Lyme disease or Bartonella or all these things. But there's such a chasm between the research kind of world and the scientists who do the research, and often the doctors like myself who are in the community sort of treating these patients. So I wish we had more money to be able to like bridge that gap, because it's so wide. And there's so many sick people, and we need the sick people's samples to be able to better inform the research, but it just doesn't, it's not really happening that I know of in like a very kind of easy to use, easy to navigate type of a format. And unfortunately, that really slows down the research and the advancement in this field.
That makes a lot of sense. Would you mind sharing a success story that you're particularly proud of, or one that stands out? I'd love to hear, if people are recovering, from neuropsychiatric conditions with Lyme treatment.
Yeah, I mean, I have so many. I could just give you like a few different blurbs of different ones so you can kind of get a smattering of an idea of some of the patients that I see. So I would say maybe a year ago, I saw a girl, a 12-year-old who was from Long Island, who was presenting only with anorexia nervosa symptoms. Um, so no joint pain, no like more medical symptoms, but they came to me because they knew my specialty, and they obviously live in Long Island, which is like tick central for tick-borne illnesses. So I did the full workup on them, and she was positive for Lyme disease and Bartonella. And I think she only got, amazingly, I think she only got maybe 1 month of treatment, maybe 6 weeks or a little bit more. But her anorexia completely went away, in the context of being treated for positive Lyme and positive Bartonella Lyme testing, um, lab testing, excuse me. So that was a really cool, like, again, when I present these cases, they're not meant to be like, oh, every single time someone comes in and we treat them with like a month of antibiotics and everything gets better. That's usually not the case, especially if it's a longer term kind of situation. We often need to do a combination of aggressive antibiotics and herbals and supplements and everything like that to properly treat things. But on occasion, we see like really dramatic, amazing results. I saw another woman who was in her 60s who had actually a history of chronic Lyme disease for many decades, but was like otherwise like pretty under control and not taking any medications and was in a good functional place. And then all of a sudden, I think last January, developed influenza and had steroids at the same time. And a couple of weeks later, developed new onset psychosis out of the blue as this woman, like in her 60s, no psychiatric history at all. So I saw her and I did the full workup. Oh, and when I saw her, it was not just like psychosis symptoms, but basically a smattering of every single psychiatric symptom. Like
Oh, wow.
she was like manic, and she was like, she couldn't have a conversation in a linear fashion, and she was all over the place. She had a lot of emotional lability. So literally she would be laughing at the first part of the sentence and crying at the second part of the sentence. It was just so nothing, not even a very specific psychiatric problem, just like all of them all together. So I did the workup and I found that she was positive for Bartonella. And I talked about that we might need to add antipsychotic medications to treat the psychosis, but I said we can try to aggressively treat this Bartonella infection that it looks like you have. And I put her on 2 antibiotics, and her psychotic symptoms totally went away within 2 months, and she was like a completely different person. Because I was worried that she also had dementia because she's presenting with like very significant cognitive problems at the same time. But her symptoms, I remember seeing them, the family, 2 months later, and they're like, she's 100% better. Like,
That's amazing. That is amazing.
yeah, so it's pretty remarkable. I've seen a ton of kids who have like OCD and this autoimmune encephalitis picture that's so severe that they cannot function. And when we get them on the right antibiotics, like the psychiatric symptoms just can disappear. They literally like, it's like I would never believe it if I didn't see it, because it's so counter and so radical, so counter to like what we know about traditional medicine. But it it's amazing. I've
That
seen
is, yeah,
phenomenal.
that's, it is amazing. And I really believe that as we keep moving forward, I think we're going to find that a lot of people that have psychiatric conditions have some kind of infection or, I mean, it would be amazing, of course, if things went in that direction and we saw people get better like that, because that's an amazing story.
Yeah, thank you. I mean, I have so many like that. I have a little kid who usually kids present with psych symptoms, the ones that I see anyway. Maybe I have a bias in the sense that I'm a psychiatrist, but I saw a 7-year-old whose parents actually had just bought a house upstate, and within a month after buying this house last summer, the kid presents with like blurred vision and these episodic neurological symptoms and pain in his legs. It was very strange presentation, but like a little kid, very concerning. So the mother of the child was friends with another mother of one of the boys in his class who I had seen at Columbia many years ago. And so credit to that woman, she's like, have you thought about tick-borne illness? Because the symptoms seem like tick-borne illness. So they came to see me. We did the full workup. He was positive for Bartonella in his blood, so we found evidence of the bacteria in his blood. We talked about all of the options that we could take a few different routes in terms of like most conservative to most aggressive treatment. So we, together we decided to treat him as aggressively as we could. And within 2 months, his symptoms were completely gone. So that's an example of we actually identified it pretty quickly within a couple of months, and we found what was going on, and he got much better. So most of the time, often like I'm seeing more patients early on, but unfortunately, when you have a delayed diagnosis and like we diagnose it years after the infection
Yeah.
has kind of been causing problems, it's a lot harder to treat.
Yes, it is. Yes, it is. Last question for you. So when you're in the process of treating and assessing why the patient is here to see you, can you differentiate between actual psychiatric conditions and then those attributed to Lyme disease or any vector-borne disease?
I mean, oftentimes it's almost impossible, obviously, to tell. Um, One of the things that can kind of make it easier is obviously if you have a known like tick attachment, like if you're otherwise well and then you
Yeah.
find the tick or you find the rash and within a few weeks all of the symptoms start, like that's easy because like okay, like we're pretty certain that this all of what you're experiencing now is directly related from in on the timeline to the tick, right? Most of the time we don't have an easy answer like that. Where it gets complicated, and I see this a lot because I see kids, is that we see people presenting with psychiatric symptoms around the same developmental time where we normally see psychiatric symptoms presenting. So, for example, anxiety, ADHD, this can be like, in your childhood years, like your earlier childhood years. But that's the same time where people can also get infections. So that's where it gets kind of tricky. Like if you have a 40-year-old woman who presents to you, she's never had any medical problems, she's never had any psychiatric symptoms. She just moved to a house in the woods and now she develops a complex like smattering of medical and psychiatric symptoms, that's kind of a slam dunk case too, because she's out of the window that we normally see psychiatric symptoms developing. And she was otherwise good, and then all of a sudden has these new onset psych symptoms. So that's like, I would put a big bet on that, that's all infection related, but oftentimes we don't know entirely. I have to explain to them like, listen, these are the reasons why I think it might be infection related. You also have positive testing. You have these symptoms that are suggestive of it, but we don't really know for sure until we go down the treatment road and we see improvement. And by the way, it's not that we start one thing and we automatically see improvement. We might need to like change up the antibiotic regimen, for example. It just kind of depends also on the infection that we're dealing with.
Got it. Well, thank you so much for joining me today. This was very interesting.
Thank you for having me.
All right. Have a good day.
Thank you. You too.